Well, good afternoon to everyone. It's an interesting topic, subacute thyroiditis. It's a very rare condition, but it's something to be kept in mind. And I'd be listening about it after a very, very long time, because in my 50 years of practice, I have seen only 2 cases of subacute thyroiditis. And I'm sure the endocrinologists have seen a lot more. And Dr. Shah is sitting next to me. He must have seen a lot more.
Yeah, I think it's a reasonably common, it's exactly where you practice is the issue, what chair you occupy. And I think if you are an endocrinologist, perhaps you will see quite a few subacute thyroiditis. And we actually have none other than Professor Satinath Mukhopadhyay, who's going to throw light on it. I think it's important to recognize this disease and treat it. And essentially, thyroid disease, so many of our patients seem to suggest that Dr. Ajibon ki oshud nite habe. I think Professor Satinath Mukhopadhyay will throw more light on it.
Thank you, chairpersons. Good afternoon, everyone. I would also like to thank the organizers for having me for this meeting. Subacute thyroiditis, with due respect to the chair, is not an uncommon disease in general practice. It's not an endocrinologist's disease. We only see subacute thyroiditis that are difficult to control. They go into permanent hypothyroidism or have recurrences, only then they get referred to us. So it's much more commonly seen by internists, and this is a sponsored talk. And I was promised a slide set by the sponsor. Then till yesterday afternoon, I did not see any slide set coming through. So after I finished my clinic, I went back to my database, which is there on my laptop, pulled up a couple of cases which I saw over the last couple of years, and I would like to walk you through some of those. I'm not sure whether you can read it from there. So here is a 47-year-old lady. She presented with pain in the throat radiating to the left ear for 1 month. If you look at her biochemistry, which is on the right panel, the TSH is lowish, but your free T4 is clearly elevated, and so is the T3. So this is a situation where you get biochemical thyrotoxicosis without the thyroid gland being active. So it's a leaking thyroid and not a hyperactive thyroid. And interestingly, this patient was on thyroxine. As you can see, 12.5 micrograms for menorrhagia. While on thyroxine, she developed this problem, and then the software actually fills up all those, the questionnaire. Even I didn't have any idea whether I documented all those things. I don't know how they do that, AI or whatever. So weight loss, heat intolerance, everything is yes, all those symptoms were there, suggestive of thyrotoxicosis. Then the neck swelling, yes. And then what happened? Well, of course, we did a technetium thyroid scan, and there was no uptake. So the diagnosis of subacute thyroiditis was confirmed. Thyroxine was stopped. The next case, 57 years female. The clock is not working. So I'm not being clocked. Sanjay, please raise your red flag when you think that my time is over, and I'll stop there, right there. This is an interesting case. Primary hypothyroid for 25 years on thyroxine. Then the patient started having symptoms suggestive of thyrotoxicosis. The TSH went down. And the physician in charge stopped thyroxine, but put the patient on carbimazole. which is the commonest mistake that we see in clinical practice. And many such cases actually land up into the clinics of endocrinologists because of this carbimazole. The patient develops a sky-high TSH, becomes myxedematous, and then seeks a second opinion, this time maybe from an endocrinologist, and that's why we see those cases landing up into our clinics. So again, another case of thyroiditis, and then just stopping carbimazole brings the situation under control. Now, this is interesting because the patient had autoimmune thyroiditis, classic Hashimoto. On top of that, they would develop these symptoms. So these patients, after remission of subacute thyroiditis, will go back to her original disease, which is hypothyroidism, and will require treatment lifelong. Sanjay mentioned that this subacute thyroiditis is a situation where lifelong thyroxine is not needed. This is an exceptional case where she will need thyroxine lifelong. 42 years, male. Interesting. Patient developed a thyroid nodule which was tender. And then an FNA was done. Because this was, nobody thought about a kind of a focal thyroiditis, and then the FNA result showed granulomatous thyroiditis. The focal presentation of subacute thyroiditis is not easy to pick up, but my word of caution would be that please don't go for an FNA in a tender nodule which is of recent onset, say weeks to months, because the thyroid as such is exquisitely tender, and then you poke your needle. Patients do not like that. TPO antibody, which is a marker of autoimmune thyroiditis, is negative in subacute thyroiditis. So because this is not an autoimmune condition, and here again you can see the TSH is almost undetectable. So another presentation of subacute thyroiditis. This is interesting. This is the patient's story in her own writing, which she WhatsApped to us. So I'm just reading it through. I've been suffering from hyperthyroidism and want to consult whatever doctor online regarding the same since I am staying in Chennai. The problem first occurred in 2019 when we were planning for a child. My TSH came as 3.7 and I was advised to take Thyronorm 25 micrograms a day. Over the next 10 days, I started feeling uncomfortable and TSH dropped to less than 0.05. So put someone on thyroxine 25 and then the TSH drops to less than 0.05 in 10 days. So this is not thyroxine overdose. So this is something else. And this resulted in significant weight loss for me. Post that, TSH fluctuated wildly between 0.05 to 80. What is missing in this story is that when the TSH dropped, the physician took the patient off thyroxine and again started her on neomarcazole. So not that it happens only in Kolkata, it happens in all the metros, Chennai included. So neomarcazole, and then the TSH shot up to 80. Then fluctuations. Since then I have been taking Thyronorm. My child was born 8 months back. Now again I see the TSH going up. Now what's happening here is that now this is the natural history of subacute thyroiditis which the patient is going through. TSH is, now the patient is becoming hypothyroid and the TSH is going up. So now she needs thyroxine and close follow-up, because once you make her euthyroid, in primary hypothyroidism, see in my practice, I usually ask the patient to come back in a year. So annual review, right? Not here. This is subacute thyroiditis. So this hypothyroidism can be transitory, 90% of the cases. So keep them under close follow-up, wait for the TSH to drop, then withdraw thyroxine and render the patient euthyroid, right? So then am I left with any other cases over here? Okay, the same patient reviewed reports, subacute thyroiditis, and now the patient, you can see, has become euthyroid and now is on thyroxine. Last case, maybe, yes. The tension, headache, and subacute thyroiditis. Currently not on any medication except beta blocker, no goiter. This is from our clinic. I don't expect you to read the handwritings, neither I can, but a couple of things are there. At the bottom, you can see our technician scan has been ordered. This is the hospital, our OPD ticket. Patient has been put on Paramet. Patient was feeling nauseous, and so this is a paracetamol metoclopramide combination. Patient was tachycardic, so got propranolol, and then at the bottom, somewhere they say, oh, case seen and discussed with me. So they don't take the responsibility, but they do ask for a technetium scan, and which shows subacute thyroiditis. Then this patient was interesting, who I saw recently, was already on maximum tolerated doses of NSAID for 2 months. Still sore throat was not responding. Biochemically, the patient was achieving euthyroidism, and then I had to start the patient on steroid. And then the patient responded very nicely to steroid, and now he's in remission, so responded to prednisolone, euthyroid now. Then maybe the last case, I'm suffering from pain in throat even after 3 months of subacute thyroiditis. This is another case, now having globus symptoms. Professor of zoology, so she did all the Googling she could, and she knew that she was now going into remission from subacute thyroiditis, still having some sticky sensation in the throat, which she herself attributed to a globus symptoms. She said, I'm under a lot of tension, should I continue to take my classes? So you just advise. Okay, so another case of subacute thyroiditis. And then technetium scan. I will show you a couple of pictures. Fever and neck pain due to subacute thyroiditis, not responding to NSAID. This lady also had to be put on steroids, with which she went into remission. The reason I put this one up for you is not to suggest that you ask for an ultrasound of the thyroid when your clinical diagnosis is subacute thyroiditis. The gland is exquisitely painful, and the ultrasound probe will make it worse. But if someone asks for an ultrasonography, what are the findings? And here the sonologist was smart enough to suggest that asymmetrically enlarged and heterogeneous left lobe of thyroid could be thyroiditis. A few small neck nodes, so suggest thyroid profile. A smarter sonologist would put in a Doppler probe and show that the thyroid is hypovascular. So, and that makes the case. So this is a standard technetium uptake with scan report, where you see absolutely no uptake in the thyroid bed, and this is a typical picture. A normal thyroid would take up more technetium or radioiodine compared to the salivary glands. So with a normal thyroid in situ, you won't see much uptake in the salivary glands. Here all the uptakes are in the salivary glands because the thyroid functionally is not there. It is affected with subacute thyroiditis. So that's the typical picture. Thyroid abscess could come as a close differential diagnosis, but the patients are usually toxic. They affect left lobe of the thyroid much more, maybe some connection to the pyriform fossa, which I'm forgetting at this point, some embryology, whatever, more common on the left side. So here's a lady with a thyroid abscess, and aspiration took care of her problems. And this does not, acute thyroiditis usually does not cause thyrotoxic blood picture. You do a TFT and it's usually normal. So SAT is a self-limited condition. It goes through a phase of hyperthyroid, which lasts for about, say, 4 to 10 weeks. Then you have a period of hypothyroidism lasting 1 to 2 months, and then there is euthyroidism. Now, having said that, it's again 15 to 20% of patients that do not have the typical triphasic presentation. They present in the thyrotoxic phase, and 10% presents in the hypothyroid phase. So you have to take a good history, do a good physical examination, and decide that this is not your garden variety Graves' disease or garden variety Hashimoto, and that this patient needs a closer follow-up. Antithyroid drugs or thyroid hormone replacement are necessary in most situations, like I said before. So 5 to 25% of thyrotoxic cases can be due to subacute thyroiditis, so it's not uncommon at all. Most common during the summer and fall, usually suggesting a viral etiology. Postpartum thyroiditis is usually painless and is autoimmune in origin, but again comes under the umbrella of subacute thyroiditis. So clinical presentations, around half of them present in the hypothyroid phase, 30% thyrotoxic followed by hypothyroid, 20%, and it's predominantly a female disease. So that's the FNA picture, but once again, I do not advise you to ask for an FNA in subacute thyroiditis. Etiology not entirely clear. There is mononuclear cell infiltration in the thyroid gland, which releases multiple growth factors that drive inflammation, and that gives rise to elevated cytokine levels. In fact, if you do an interleukin-6, which had become very popular during the COVID pandemic, so you may see elevated IL-6 in subacute thyroiditis. Amiodarone, interferon alpha, interleukin-2, and lithium, they are potential cause of drug-induced subacute thyroiditis. And then, of course, rarely you can get subacute postpartum thyroiditis, which is rare. Usual postpartum thyroiditis is a painless condition of autoimmune origin. So this cartoon nicely depicts the natural history of subacute thyroiditis with respect to the thyroid hormone profile. You can see how the T4 level is going down, and then the T4 level is going down. The patient is becoming hypothyroid, at which point the TSH level goes up, and eventually euthyroidism is restored. These are some very rare but additional causes of subacute thyroiditis, radioiodine therapy, external neck radiation, paraneoplastic manifestation of renal cell carcinoma has been reported to cause subacute thyroiditis. Association with Switch syndrome has been reported, febrile, neutrophilic, dermatosis. So subacute thyroiditis is skin rash. So that should be a red flag to search for Switch syndrome. Then concurrence with giant cell arteritis, and recently reported after bone marrow transplantation for chronic granulocytic leukemia. COVID-19, just look at the growing number of publications. COVID-19 and subacute thyroiditis. So many papers, people looked into it. Virus was isolated, COVID virus, from the inflamed thyroid tissue, and that makes the point that etiologically linked COVID and subacute thyroiditis, and most cases resolved just like any other case of subacute thyroiditis. The prognosis is excellent. Complete recovery is a rule in the majority of cases. But having said that, permanent hypothyroidism can be there in 5 to 10%, and those patients would require thyroxine therapy lifelong. Recurrent subacute thyroiditis, we have experienced with multiple cases. I think Dasharatha is here. He may have seen more cases than me. We really struggled with those cases, and I still recall having to subject 2 patients after 4 recurrences to thyroidectomy to cure subacute thyroiditis. And one patient, once the patient became euthyroid, on the 4th recurrence, I had to ablate the thyroid. So those are my experiences. Recurrent thyroiditis, very rare, but can be very troublesome. One patient who underwent thyroidectomy actually had 4 recurrences within a year and was about to lose her job. frequent absences from the office, so eventually thyroidectomy. Differential diagnosis not much. To differentiate it from Graves' disease, the T3 in nanograms per DL to T4 microgram per DL ratio is almost invariably more than 20 in Graves' disease, and here it is always usually less than 20. ESR, CRP, they are all elevated. You may have a little bit of neutrophilic leukocytosis. Postpartum thyroiditis, as I said before, is typically painless and is an autoimmune condition. Treatment NSAID is effective in most cases. If the patient doesn't respond to NSAID in a month's time, you may have to treat the patient with steroids. But the main point here is do not start carbimazole or lethimazole. They have no role in the treatment of subacute thyroiditis. This is not a hyperactive thyroid. This is a leaky thyroid. So giving anti-thyroid drugs is not going to be of any help. On the other hand, once the store of thyroid hormone is exhausted, this neomarcazole or methimazole will make the patient quickly hypothyroid, and the patient will start having problem and seek second opinion elsewhere. The simple algorithm is a mild symptomatic SAT, mostly NSAID, not responding, corticosteroid, moderate to severe SAT. You can start with corticosteroids. The two regimens have been compared head to head. So 40 milligrams prednisolone daily for 1 to 2 weeks, then taper it down, or prednisolone 15 milligram daily and taper it down. End results remain the same. Are there any other slides? No, okay. So that brings me to the end of this presentation. Thank you for listening, and I'll be happy to answer questions or comments.
Thank you, Satinath, for that lovely practical lecture. So I think the take home largely was that if you have one form of thyroid disease, it doesn't mean that you can't have another one. That is the most important thing that you need to basically realize. And then obviously keep in mind the subacute thyroiditis. I have never faced patients with so many episodes as you have described, but it can be fairly painful and difficult for patients, and they do need steroid dose. Sometimes steroids have had a bad name in terms of it will produce so many side effects. So I think we just need to explain to patients that this is only for a fairly short period of time, and then you can taper it off reasonably well. And there are patients who are fortunate where patients do become euthyroid, and you may not need to continue with the levothyroxine essentially. That's how it is. Any questions
absolutely.
from the floor?
Couldn't agree more.
I would just like to ask one question. The few patients I have seen, my primary point
Sir, could
of
you speak closer to your mic? You're not really audible.
Is it audible now?
Yeah, that's better. Yeah, please.
You see, the few patients I have seen, the main reason I thought about it was because of the tenderness or pain in the thyroid, which is very uncommon with most other thyroid diseases. And they were both diagnosed on technician scan. And fortunately, like Dr. Shah's cases, they all responded very well to NSAID and steroids. And I followed them up for next 3-4 years, and I advised them to come for just get a TSH done. I warned them about it, obviously at the start, that you have to take steroids because so far we do not know of any other thing because it's an immune-mediated disease, and steroids are the safest and immune suppressant that we know so far. How long? I stopped seeing them after 3-4 years because patients remain euthyroid, fortunately, because I've seen so many patients. How long do they need to be followed up?
Sorry, the last part of the comment I didn't
How
get.
long do you want to follow up patients with subacute thyroiditis once they have become euthyroid?
Usually, those who are destined to become permanently hypothyroid or thyrotoxic, they do so within a year, majority of them. But if you search the literature, a recurrence of SAT has been reported 20 years after the initial event. So maybe more vigilance is needed for the first year following the episode of SAT, and then you can keep, if the patient is euthyroid, keep them at least on an annual follow-up indefinitely, maybe. That would be my strategy. Thank you.
Thank you.
I have an interesting case that I remembered that I saw during my PG days in SSKM. A lady, 25 years old, presented with, after 2 months of pregnancy, she was diagnosed as having panic attack because of palpitation, fever, etc. Subsequently, she was found to have high TSH. She was put on, if I remember correctly, it was 9 or 10. She was put on 25 microgram of L-troxine. Within 2-3 weeks, it dropped, TSH level dropped to 0.25. So the case was reviewed. It was diagnosed as subacute thyroiditis. Subsequently, about a month or so later, she presented with a history of intense headache of some duration, and she gave a history that when she bends down to pick something, she feels graying of vision, what we call visual obscurations. She was then diagnosed to have idiopathic intracranial hypertension. It was in close association with subacute thyroiditis, number one. And the second case, of course, it was not proven. A lady presented with several episodes over 6 months or 12 months of encephalopathy. It has been reported with subacute thyroiditis. And you have mentioned about giant cell arteritis. There is some association with giant cell arteritis also. Thank you.
Hashimoto's encephalitis is a different entity. Usually the patients are not clinically or biochemically hypothyroid. So this is a chance diagnosis in a comatose patient. I mean, when the endocrinologist is called up to see the case, so you make a diagnosis, treat the patient with steroid, and the patient comes out of danger. Thank you.
The session. Thank you.
Thank you. Thank you very much.
Thank you,
Mukhopadhyay.
speaker and chairpersons. Kindly stay back, sir, for the felicitation. I would like to request chairpersons to kindly felicitate our speaker today. Thank you, sir.